I'm here. I'm here to continue on the topic GI symptom, and I guess you have had already a session on nausea and vomiting and constipation, and today we will be morely focusing on malignant bowel obstruction. Okay, let me just share my screen. Yes. Is my slides changing?
Yes, ma'am.
Okay. Yeah. So, you are all practicing in your field. Maybe most of you are already in palliative care sector, but definitely all of you will be seeing patients with these kind of symptoms. That is having constipation or bowel obstruction. Some of you may be seeing bowel obstruction as well. So you all have been managing in whichever way that is followed in your institution. So this class is basically meant to do a little of unlearning sometimes and also sharing information that what all of you practice in your place, and it's a mutual learning that we will have. So you can always use the chat box to put in your answers, your queries, something you would like to share. Okay, so with that we shall move on. So I'm just going to actually revise you on constipation before we go on to bowel obstruction. Okay, so constipation, as you would have already had your class on. So what is exactly constipation? Do you remember that? Constipation. Yes, you can use the chat box. You can just type it there. What was exactly constipation? Only good afternoons in the chat box. Nothing on constipation. Yes? So constipation is something which is different from the normal, isn't it? So it is something which is different from the normal. Somebody may tell you, I'm constipated for 2 days, and it may be that that person is already passing motion for like 3 times in a day. But somebody may tell you they are constipated for a day, when that is usually normal for them. They may be having a regular bowel habit every alternate day. So it's all about how different it is from their normal, right? And we have seen symptoms of constipation, all the different symptoms like nausea, vomiting, abdominal pain, right? You must have also been told about overflow diarrhea, and sometimes how the rectum is so loaded that it puts a pressure on the bladder, and there is retention of urine, right? And then you must have also seen the different reasons or the different causes why someone develops constipation. It may be the medicines they are on, or maybe something in the blood, some parameter is deranged, like the calcium levels are high, or the potassium levels are low, or that there is some kind of kidney impairment. Patient is just dehydrated, or maybe the food. The patients are not able to take enough liquid, and poor food intake, or maybe it's just because they are not in the right environment. Privacy factors, right? So there are so many different factors. You all must have seen this. So you have to assess your patients, and you move on to managing them, correcting the correctable, using laxatives, right? And not just using laxatives, your patient may be having pain. Your patient may be having nausea, vomiting. So you are going to manage nausea and vomiting. You are going to manage the pain. You are going to manage the constipation also. And also the other non-pharmacological managements, ensuring that the privacy is also secure of the patient. Okay. So with all of that, right, we move on. Yes, there's also a note here on manual evacuation. Well, actually, the reason I am showing this is because I just had it on the slide and I thought, why not revise it again? Okay, before we move on. So, coming on to today's topic, intestinal obstruction. So, what is intestinal obstruction? And in this class, we will be seeing what are the different types of intestinal obstruction. What would someone with intestinal obstruction present to you with? Right? So say suppose you are going to a patient's home and they are telling you, I am having severe nausea and vomiting, not past stools for about 5 days. And what is it that will help you to decide, am I looking at constipation? Am I looking at bowel obstruction? Okay, so diagnosis of intestinal obstruction. And also how to manage once you know once you know that it is bowel obstruction, how will you manage a patient? So these are the things which we will be looking into. So like I said, what are the different types of intestinal obstruction? So you will have something which is obstructing the intestine. So the intestine is like a lumen, no? It is hollow. It is so there is something which is obstructing it mechanically, which is not allowing the fecal material to pass through. So that we would call as mechanic. Well, if the intestine as such, it is not able to push the fecal mass forward because of some mechanism. Does someone want to say something? All right. So if there is a mechanism where there is no movement of the intestine to push the fecal mass forward, there's a loss of function. That's when we call it non-mechanical. Okay. So non-mechanical, it can be because of a paralytic ileus, all right, or adynamic bowel, like we call it. Okay. There is no dynamic in it. It's just stationary there. Okay. It's because of the absence of the normal peristaltic contractions. So what happens in such a case? The pain is lesser. The bowel sounds are absent on when you're trying to check for some signs which which will help you differentiate, is this a mechanical obstruction, is this a non-mechanical? So maybe just examining so much information you can get with it. Okay, so in a mechanical obstruction, it can be anything. It can be sudden, it can be slow. Okay, so it can be acute or chronic, or it can be in the small intestines, it can be in the large intestine. So you have a small bowel or large bowel obstruction. Okay, so sometimes it's a simple obstruction, sometimes there is like a loop which is formed, and it's like closed loop obstruction, or it can be strangulated. Even the blood supply is cut off because of the mechanical obstruction. So it could be strangulated. Now it can be also something like which is intrinsic, where the obstructing, probably it is a tumor, it is inside the lumen, it is obstructing the lumen, the opening. Or it can be extrinsic, when there is a mass or a tumor mass outside and it is obstructing. Now you cannot see the opening, isn't it? It's obliterated. Or it is intraluminal. Okay, it is through the wall that the tumor has invaded through. Okay, and causing the obstruction. So these are the two different types, basically, the non-mechanical and the mechanical. Now it can be simple if it is just one obstructing point. Okay, it is that obstruction is only at one point, or it can be at 2 points. Like I said, it's just the intestine is like formed like a loop, and there is a 2 points at which there is obstruction. Or it can be strangulated. Like I said before, the blood supply itself is compromised. And for such cases, it is more of a sharp pain that the patient has. Okay, the patient may also have melena. It is signs of mesenteric ischemia is what we say. The blood supply of the coating around the intestines, the peritoneum is getting cut off, and this will cause some peculiar features like severe sharp pain, fever, okay, and also melena, the bleeding, okay. Now, what can be the causes of mechanical obstruction? Okay, what can be the causes of mechanical obstruction? Well, there are causes like you may have stones, like foreign bodies, right? Or it can be, some patients who are taking radiation therapy, or they have had multiple surgeries for various reasons. So what happens is that in the abdominal cavity, there are some adhesions that is formed. There is almost like a sticky nature of the adjacent organs or important structures, which will kind of yank the intestine. And that itself can cause the flow obstruction. It can be strictures that is formed. Okay, there is a little kink that has happened in the wall. So all this can be different reasons why mechanical obstruction occurs. So repeated surgery, repeated radiation, all this can make you think, okay, am I looking actually at obstruction, intestinal obstruction? Is this actually just a simple constipation or a intestinal obstruction? Right? So these are all different causes. So what are the different symptoms that a patient with mechanical obstruction will come to you and tell you? Yes, I am sorry, I didn't see the chat box. Shania has said about constipation being less than 3 to 4 stools per week. That is right. And Sunita says about the slow bowel movement, and Shania also says about hard pieces straining at defecation. So that's all about constipation. Thank you so much for those answers. So, like I was saying, we were talking about what are the signs or symptoms or the complaints that the patient is going to tell you when the patient has mechanical obstruction. When the patient has intestinal obstruction.
If it is, may I answer?
Yeah, sure. Yeah.
May I answer? I'll attempt.
Yeah.
Sometimes I have observed thin, streaky stool. They feel the pressure, urge to pass, but when they go, they have very thin narrowing of the stool.
Absolutely. Okay, and, absolutely. Yeah. So there some amount of fecal mass is passing through, right? But still completely they are not able to pass. So through that small little aperture, there is a thin ribbon-like stool that is passed. Very typically told by a lot of patients. That's absolutely correct. So there we would say it's more like a subacute intestinal obstruction rather. Okay. So where also Sunita also tells them not able to pass flatus. Now this is something that we would see in an absolute obstruction. Okay, when it is a adynamic bowel, like how I was telling you earlier, it's a non-mechanical obstruction. Probably there is no dynamicity seen in the intestines, and there is no bowel sounds either when you are auscultating, and the patient complains, I am not passing flatus either. Right. Yes, Sunita also says about abdominal distension. Absolutely. So the patients might tell you that my abdomen feels so distended. Yes, Gurkaran also says about inability to pass wind and stool. Absolutely, that is flatus, right? So the inability. And Shania was also talking about tenderness and mass. Yes, if it is a pelvic mass that is obstructing it, you can actually feel the mass that is there, and the patient may also be having colicky pain, right? I would like to stress the word colicky over here, because as you know, the intestines have a peristaltic movement, like a wave. So what happens is that when there is an obstruction, the peristaltic waves, they tend to mount one another and tend to present like a colicky pain. Okay, so very typically said of a colicky pain, a pain that is very gripping in nature and fades off and comes back. So that is how we typically ask for the abdominal pain. Okay, so yes, no flatus, no stools, tenderness, pain abdomen, distension. Anything else? Anything else in intestinal obstruction that your patient would come and complain to you of?
Sometimes vomiting.
Yes, yes, Shania. Sometimes they could even have nausea, vomiting. Okay, so all these are different complaints that a patient may come and tell you. So why is all this happening? Causes of the symptom. So it can be a complete obstruction or it can be a partial obstruction. So the thing is that these patients have severe pain. It is colicky in nature. This is because of the bowel contractions. Okay, so because there is a bowel a distension that is happening, like how you were saying, right, in the chat box, that there will be the patient says my bowel is getting, my abdomen is feeling so distended. So basically there is bowel distension happening because of the obstruction, and this is because of the pooling of the bowel contents. Now there is also the fecal content, there is also the increased bowel secretions that is happening. Now this is because when the distension occurs, the gut epithelial surface area is also getting stretched. So when the surface area increases also, it adds on to the bowel secretions. Okay, so if a patient says that, oh, my mother is not past stools for 5 days, but you know she's not been eating either, so probably that is the reason. So what you have to tell the family is that, see, even if your mother has not eaten food, it is quite possible that there is some fecal content which is led on to the constipation. Because even if there is no food being eaten, there are bowel secretions which mount to fecal mass. So now with all these secretions, there is nausea and vomiting happening. Okay, so that is why the patient might have nausea and vomiting. And there is a whole inflammatory response that is happening there. Like lot of factors, inflammatory factors are being released because of the damage of the epithelium of the bowel, which leads on to factors which give rise to pain, continuous pain. Okay, now this aggravates further the colicky pain. So this is how the symptoms are caused, because there is an obstruction, there is decreased intestinal contents movement, and there is distension. When there is distension, there is also increased secretions that is formed. All this mounting on to increased pain, and again the secretions leading on to nausea and vomiting, and this is just a vicious cycle. So what can you do? So how will you manage a patient who you think is having intestinal obstruction? So tell me one thing, do you think we will be able to palpate a mass in constipation also?
Yes.
Yes, isn't it? So especially if the patient is lean and the patient is having a loaded colon, it will be a loaded colon will be palpable when you try to palpate the abdomen. Okay. Yes. So let's get back to the question. So how are we going to manage this patient? Okay. So yes, Sunita tells that we can give an enema, put the patient on nil oral. Okay. Seema says that let's give an enema. Okay. Gurkiran says that let's again put the patient on nil oral. Okay. That's what we all see, right? In our practice, most of these patients, they complain that they are having constipation. I mean, you are suspecting intestinal obstruction. There it goes. NPO. Right? So, yes, Shani says that yes, we have to start the patient on IV fluids and also relieve the colicky pain. I like that you have addressed that, symptoms first. So if your patient is in front of you with severe pain, with severe nausea and vomiting and having an intestinal obstruction, let us not get deviated by only managing the intestinal obstruction, but also emphasize that we have to treat the pain, we have to treat the nausea and vomiting. Okay? Yes. What else? Let us see. Now again, it is also important to know where is this obstruction. So how are we going to know where is the obstruction? So sometimes it may be in the small intestine, sometimes it may be in the large intestine. Now you would think that how are we to know where the obstruction is? Don't we have to take a CT scan? The answer is, if you are at the bedside of the patient, a good history taking will give you some tips on where the obstruction is. If the patient is having a large volume of vomiting, okay, the patient or the family says that I don't know how he or she is vomiting so much. It's like 10 times the amount of sip of water that he or she probably has had. So then there is a large volume of vomiting. So when there is a large volume of vomiting, you should suspect that the obstruction is in the higher level, most probably in the small intestine. Whereas if it is more of the abdominal distension that the patient says and is more progressive in nature, there is some vomiting, things like that, then probably it is a large intestine that is involved. And if there is no passage of wind or flatus or no fecal material at all, we are looking at complete obstruction. Okay. Sometimes what happens is that patient may keep complaining of trickling stools, loose trickling stools. Now this is when you have to ask the big important question: when was the last time you had a normal stool? And very classically they will tell you that, oh, last normal stool was last week. After that, for few days there was no stools at all. It is only for past 2 days that there is this liquid little stool that is just keeping on going on and on. So then it should click you that you are looking at spurious diarrhea, which is actually constipation induced rather than a typical diarrhea. Okay. Yes. So, well, in the chat box, Sunita says, yeah, we could give tramadol for the pain. And Shani also says, let's do an ultrasound of the abdomen to see. Sunita also says, let's do an ultrasound. Okay. And then Sunita also says, oh, probably a barium enema. Okay. So, yes, barium enema may give you some idea on probably is there some obstruction there. Right, and ultrasound may give you some information like, okay, is the is the colon loaded, or is there a mass that is sitting there, things like that. Okay, so we need to know a little more, isn't it? So yes, Shani was saying about colonoscopy. Yeah, definitely. Now, this is a little more invasive, right? We have to post them for the scopy, and then, it's basically something that we are intervening, putting a tube in there. Is there something very simple that you can do without any intervention, just giving us a clue? Okay, we are looking at a typical bowel obstruction.
Auscultating?
Auscultating, okay, it may fall into that category of no intervention and, no bowel sounds. Okay, definitely. But what other investigation? Radiological investigation.
Simple X-ray.
Absolutely, absolutely. And when you are taking an X-ray, there is a very typical posture that you want for this patient. Any idea?
Can't recall, ma'am. Sorry.
It is an erect position. Okay, the patient should be standing. Okay, so the thing is that you need an erect X-ray. So what happens? An erect abdominal X-ray. But what happens is that sometimes you are not aware why it is so important. The posture should be important to know what exactly, to get the typical signs of this abdominal obstruction. So if your patient is absolutely bedridden, saying that, oh, I'm having severe pain, how can I go to the X-ray department in the wheelchair? I don't think I can sit on the wheelchair. So then you think about, okay, let's get a portable X-ray to the room and let's take an X-ray. But now what happens here is that taking an abdominal X-ray in the supine position may not give you the typical signs. Okay, and so I shall show you an X-ray, and this is how that X-ray will look. We call this sign as multiple air fluid level. Okay, so what I want to show you here is that you can see the black shadows. Let me see. Let me get my pointer here. Okay, you see the black shadows here, right, in the abdomen, and you see this little U-shaped structure. Okay, that is a big distended large colon over there. And do you see that how it just ends in a flat line? The end of it, see, it's
Yes.
just like as if it's cut with a
Steps.
scissor, right? Yeah. And that's exactly what the typical sign of a bowel obstruction is. You can see like a correct one line is drawn. That is what we call as the air above and the fluid below. Okay, this is the black is the air above, and below that line it is a fluid. Okay, so this is what we do to okay, this is what we basically do to check if there is a bowel obstruction. So now what do you do to treat your patient? Well, we did get some answers here like pain management, then also enema, things like that. Okay, now when it comes to bowel obstruction, okay, you have a malignant mass, a cancer tumor sitting there and completely obstructing the intestine, and maybe your enema might just help to like send out some fecal material, but that's it. How are you going to plan further for this patient? What can be done? So this is an algorithm which will help you plan for the patient. Okay, so the patient presenting with symptoms of bowel obstruction, you do a clinical assessment. Okay, that is, you take a history taking and then you examine the patient, do a clinical assessment, then you go for minimal radiological assessment. If you are at a setup where you do not have facility for CT scan, do a X-ray, a erect abdominal X-ray, look for those typical signs. Okay, and then again, to know further, you might have to do a CT scan of the abdomen, right? And again, when it comes to malignant bowel obstruction, it is because of cancer that the bowel is completely obstructed there. then the point is, do you have to go for a surgery? Does the patient have to go for a surgery? Okay. Do you refer the patient to a surgical oncologist for so that the obstructing part can be cut and the other parts can be fused, which we call as anastomosis. Okay. So these are some factors. One, age of the patient. Okay, as much as I have put age as number one over here, what I need to again emphasize is that age is a number, is just a number. So what is most important is that the performance status of the patient. So you may have a 65-year-old patient who is up and about, still leading the family and taking all the decisions, doing his routines on his own, completely not dependent. But at the same time, you may have another patient who is having an advanced disease, 60-year-old, completely bedridden because of multiple comorbidities. Okay, so age is just a number, but again, it's performance status that we look more than the age. Now, the stage of cancer, are we looking at some early stage cancer or are we looking at an advanced stage cancer? Right? So, if we are looking at an early stage cancer, we have to refer the patient to the surgical oncology department so that they can plan for the further resection of the tumor mass, the obstruction area, and anastomosis, right? Or sometimes you must have seen a colostomy is put out, right? The tumor area, the obstruction mass is cut out, resected, and then the proximal area is brought out of the abdomen and attached to a bag, right? So until the treatment is done and the cancer is treated. Okay, so this is the surgical procedure, but who all should go for this? That's what we are looking at. So the stage of the cancer, if it is the advanced stage, patient is almost terminal, then there is no point of us thinking for surgery, right? Because the surgical procedure itself may be more burdensome for the patient rather than the current condition. Now, the future anti-treatment options. If the patient is in the early phase of the disease and the patient now, because of the obstruction, the physicians have suspected, okay, now the disease is getting a little worsened. So let us shift the treatment to probably another protocol of chemo so that the disease can be brought into control better. So understand what is in plan for the patient. Is the patient malnourished, cachexic? If the patient is malnourished and cachexic, your patient is not going to tolerate any surgical procedure. And if the patient is having any concurrent illnesses, like say some kidney failures or liver failures or a cardiac patient and things like that. So all this contributes to decision making. Again, this is all the patient factors. When you're looking at the disease factors in making a decision, it would be, where is the obstruction? Is it just at one point? Okay, if it is at one point, you can cut, the surgeon can just cut it and remove it. What if it is at multiple levels? How much can he cut? So the thing is, the extent of the obstruction, the site, is it proximal or distal? Okay, is it higher or is it in the lower area? Now, the etiology, is it functional or is it mechanical? Is it because that actually there is a mass sitting there, what we were saying mechanical, or is it because the intestine itself is not moving? It has lost the ability to move. So what are we going to actually resect there, isn't it? So ascites is a condition when there is a peritoneal spread of the disease mostly, and there is cancer cells in the fluid, okay, and this will carry a poor prognosis for a patient who you want to plan for surgery. And carcinomatosis peritoniae. Carcinomatosis peritoniae is nothing but, there is what can I say, a sheet like structure which is surrounding all the organs in the abdomen, and this is called peritoneum, okay, the peritoneum. And when it is studded with multiple tumor masses, small tumor masses all around it, we call it carcinomatosis peritoneum. Okay, so if there is a carcinomatosis peritoneum, again it is a bad sign. Okay, so this is all just an algorithm to help one plan for a patient what has to be done. So poor surgical prognosis would be advanced age with cachexia, wide tumor spread, ascites, low serum albumin. We all know that when the protein levels in the blood are low, that is when the albumin levels are low, there is always a chance for further ascites, and there is always a chance of higher morbidity when there is a persistent low albumin level. Okay, the chances for recovery is very less for that patient. Okay, especially from an acute procedure and things like that. Now, severe nutritional deficiency, palpable abdominal mass. Now you know that if the mass is really huge, again that is a bad prognosis. Previous radiotherapy to the abdomen and pelvis. Why? Because we told that previous radiations and surgeries to the abdomen will give us a hint or a clue that maybe there are a lot of additions and sticky areas within the abdomen which is pulling and yanking the intestine inside. History of combination chemotherapy, history of multiple lines of treatment which is given for the patient. So, which shows that the disease is a tough disease. So, there is low chances of recovery for this patient and higher chance for this patient to worsen further. Okay, multiple lines of obstruction, sites of obstruction, and poor peristalsis or poor performance status. All these are reasons which we would say is poor surgical prognosis factors, and which will tell you, okay, this patient has to be managed conservatively. Conservatively would mean without any intervention with medical measures. So then comes the question, what medical measure? What are we going to do? What are we going to give? Enema, like you said, laxatives can be given for a patient. Patient presented with pain, okay, you are giving analgesics for that. Now what next? How can you, there is a tumor mass sitting there and which is causing the obstruction, okay, which is causing the obstruction, and the lumen, that is the opening of the intestine, is like almost obliterated. Now how are you going to medically manage this? Yes. Yes, any ideas? How are we going to medically manage that tumor mass, which is closing the lumen of that intestine?
Chemotherapy?
Chemo can be one, but it's going to take time, right? And the patient may be, if the obstruction continues further, the patient can go into kind of toxicity. Radiotherapy? Any other options? Cryotherapy? Okay, something which you and me, everybody can do. Let's put it that way. Okay, we do not know how to give chemotherapy, or we do not know how to give radiotherapy. We do not know how to do surgery either, right? But what can we all do? Okay, Sunita talks about total parenteral nutrition to maintain the basically the nutritional status of the patient. Okay, right? We'll come back to that. It's a very interesting topic to discuss on. So we need to actually bring down that tumor mass, right? Something which we all can do. Now that's what we are looking at. Now that is where we give the patient corticosteroids. Now under corticosteroids, I am particularly trying to focus on dexamethasone. Injection Dexona is what is very commonly written. Okay, and now why do we give a steroid? Why do we give a steroid in such a case? What is it going to do to that tumor mass? Does steroid help to shrink cancer tumors? Yes. To reduce the edema is what Sunita says, absolutely. Okay, so every tumor mass, as you know, it will have an edema around it. Okay, so what you can do is that if this is the lumen of the intestine and you are having a tumor mass sitting there and obstructing the lumen, okay, there's hardly any space there. There's hardly any space there. Okay, so what you should understand is that this tumor mass has a layer of edema around it. So by giving the corticosteroid, that is dexamethasone injection, you are going to reduce the edema around it. So when the edema reduces, there is going to be some decrease in the size there, and you can see the lumen is partially open now. Okay, so that's exactly what the magic of dexamethasone is. So the only thing is that dexamethasone is used at a little more higher dose than we usually give in normal practice. Okay, so injection dexamethasone is given at a dose of 16 milligram to 24 milligram, and the range of that. Okay, generally in my practice I give 24 milligram. Okay, 24 milligram of dexamethasone diluted in 100 ml NS. If you want to, you can run it over like 10 minutes. Yeah, and this can be given IV once daily for 3 or 4 days. Okay, that is how we manage. Why we do not give dexamethasone as straight IV push at a higher dose like this? Have you tried giving dexa shots? Straight IV push? Something that your patients tell you? Vomiting? No. Patients would say that they feel very strange. They feel as if some kind of crawling sensation, especially in the anal area. They will feel like a little crawly kind of sensation, So sometimes it's all over the body. It's a very strange feeling. They can't tell you what it is. So that is why dexamethasone, it is better that, yes, Sunita was saying about the itching in the vaginal area. It's more like, even though it's not like itching, it's more like a crawling kind of sensation. They're not able to describe it. So that is why especially dexamethasone is given as diluted. Okay, and the thing is that dexamethasone has a longer duration of action, so you really don't have to repeat it every 8-hour day. Give it as a once daily dose and try to give it before evening because it will interrupt with sleep patterns. So try to always give the dose before 6 p.m. Alright, and why give it only for 3 to 4 days? We are checking at the same time every day. You are checking, asking the patient, did you pass flatus? Did you pass wind? That is the first sign. Or you can auscultate the abdomen and check for bowel sounds. Okay, so slowly there are changes that are occurring. Okay, and at the same time, if the patient is having having nausea and vomiting, you know that there is a lot of increased secretions that is happening in the intestine. We saw that chart over there, and that is the reason why he is having vomiting. A lot of secretions happening there. So antiemetics also, you have had your class on antiemetics. A lot of drugs which are used for vomiting. So you need to wisely decide which medicine should I use here for a patient with nausea and vomiting who has also bowel obstruction. So you need an antiemetic over there which will help to maintain the activity of the intestine forward. But what if your patient is having severe pain? I told you with obstruction, when the peristaltic waves hit the obstruction site and next peristaltic wave comes, that also hits. It's like bowel contractions. They tend to jump one on top of the other. Patient has severe colicky pain. So what if you are giving a drug like perinom, metoclopramide? So perinom, what it does is that it helps to stop the vomiting by stimulating a forward movement of the esophagus and the intestine, the GI system basically. So what happens here is that it makes the process more faster. The pain is going to increase. So for a patient with pain, abdominal pain, do not give perinom. If your patient does not have any pain, okay, fine, you can try perinom. Maybe it will also help in relieving the bowel obstruction, in the sense like the fecal movement. It will try to enhance it. Okay, and antiemetic, you can try ondansetron, but you also need to keep in mind that ondansetron does cause constipation. You can try haloperidol, Serenase. Okay, Serenase can be given at a dose of like 1.5 milligram. Okay, so 0.75 to 1.5 milligram dose range. Okay, it can be given 8 hourly. And anticholinergics is something which I also prefer because it helps to reduce secretions like Buscopan, hyoscine butyl bromide. Okay, that's a generic name. So Buscopan is usually helpful in reducing the intestinal secretions and thus helping to reduce the vomiting. Same goes for other somatostatin analogs. Another agent which is used for vomiting, like octreotide. Octreotide, a more expensive version of an anti-secretory agent. Okay, now analgesics is another thing that we were saying, right, to bring down the pain. Yeah. Yes, Sunita was talking about the prokinetic, Seema was talking about the gastric problem, right. So then another treatment is surgical, where you talk about where, you know, more of the resection of that bowel segment which is having obstruction, and a colectomy, okay, and a ileostomy where the ileum, the small intestine, is brought out, or it is colostomy where the large intestine is brought out. Now, ileostomy, when the small intestine is brought out, it is very troublesome for the patient because there is always going to be a lot of secretions that is happening. The bag, the colostomy, ileostomy bag keeps getting filled up all the time. It is not like colostomy. Okay. Now, invasive procedures like nasogastric tube insertion, gastrostomy for feeding, or colonic stent where there is a stent which is put up and the lumen is opened with the help of a stent. Now, nasogastric tube insertion is done when there is a lot of abdominal distension and the patient is feeling very discomfort because of the distension and feeling nauseous, vomiting is not getting controlled enough, and you somehow have to deflate the stomach and take away all the secretions over there. So that is when you put the patient on a NG tube, a Riles tube. Now, literature says that you can allow sips of fluid if the patient tolerates. The catch is if the patient tolerates. The patient can take sips of fluid if the patient tolerates. So we allow that. So antiemetics, metoclopramide, dopamine antagonist, you can start it at 10 milligram, 8 hourly. You can keep increasing the dose, all right. Or sometimes when IV access is difficult, subcutaneous access is also there, which is very commonly preferred in palliative care. And again, 5-HT3 antagonists. What we mean here is ondansetron, emisset. Emisset also can be tried, okay, and prokinetics like metoclopramide can be tried only in partial obstruction. Okay, if you're having some small minimal bowel sounds which you're thinking is a partial obstruction, okay, then you can go for metoclopramide. Okay, but if it is a complete obstruction, do not go for metoclopramide. Now, haloperidol also can be used. Now, anticholinergics, we were talking about Buscopan, isn't it? And we were talking about corticosteroids, dexamethasone, 16 milligram to 24 milligram in a day, IV, right? And we did talk about the 3-day trial. Okay, if it is a severe advanced disease, or after the trial, the patient can be tapered down the steroids, okay, and continue as oral steroids before it is completely stopped. Octreotide can also be given, okay, and it is costly, can be given subcutaneously as well, can be given along with steroids. So typically a prescription for intestinal obstruction is going to look like this. Okay, I have written here 8, but definitely it is 16 to 24. Please make the correction there. 16 to 24 milligrams subcutaneously IV for 3 days. Okay, and you have to combine it with an antiemetic. And if it is a partial obstruction, you can go for metoclopramide where there is no abdominal pain. Okay, and you can also try anti-secretory like hyoscine butyl bromide if it's a colicky pain, to reduce the secretions and to reduce the colicky pain. One thing you need to know, do not combine metoclopramide and hyoscine butyl bromide because they cancel each other. Okay, do not give both to the same patient at the same time. Haloperidol can also be given. Okay, so this is just a diagrammatic representation showing how a stent can be helpful in case of an intestinal obstruction. Okay, that stent is just being placed like that and then it is expanded. So you can see when the stent expands, there is a lumen that is opening up or created. Now comes the common frequently asked questions. Hydration, oral feeds, total parenteral nutrition, nasogastric tube. All these are different questions that the family or the patient is going to keep asking. Can't we go for this? Oh, so much of vomiting. Shouldn't we give IV fluids round the clock? Is this IV fluid enough? Shouldn't we give more? Nothing is going in, nil oral. Or can we give something orally? They've not eaten anything. The patient has not eaten anything for so long. Can sips of fluid be given? Or shouldn't the patient be put on total parenteral nutrition through a central catheter? So what do you think? Can we hydrate? Since a patient is nil oral, a patient who is having severe nausea and vomiting and having intestinal obstruction, are we justified in giving high volume of IV fluids? What do you think? Can you use the chat box? So do you think that we should give high volume of IV fluids? The patient is having severe nausea, vomiting and is having a bowel obstruction. You put the patient on NPO. Yes, nobody has anything to say. You can say yes or no, right? No, the patient should not be given, is what Shani says. Okay. Any other answers? Yes, no, yes, no. Sunita says also no. Okay. Seema also says no. Okay. Anybody else wants to join the group? Ankita says no. Okay. Poonam also says no. Okay. Everybody says no, no, no. You can't give too much of fluid. Okay. Right. So to all of you there who are confused, should we not? That's probably the reason why you do not want to put the answer here. Okay, there is no right or wrong over here. We're just simply discussing, right? So the thing is that when we are overhydrating the patient, we know that we saw that diagram there, right? When there is a lot of pooling of secretions happening. So that is in turn leading to the vomiting. So what is going to happen when you are going to overhydrate the patient? This is in turn going to go in as more of secretions in for the patient. Okay, you're overloading the volume, and that in turn is going to cause increased secretions for the patient in terms of vomiting, right? And it is going to not be helpful, is what I would want to say. So hydration has to have an equal balance. You can hydrate the patient, but not overhydrate the patient. Oral feeds, like I said, you can try sips of fluid, that's not a problem. Total parenteral nutrition, generally, you do not give total parenteral nutrition to a patient if that patient does not have a prognosis more than 3 weeks. So a patient who is advised total parenteral nutrition should have at least 3 weeks of assured survival. So total parenteral nutrition, as you know, you cannot give it through a normal cannula, right? But now pericabivan is available, yeah. So that you can try. Total parenteral TPN is usually given through the central line. Now, nasogastric tube, again, we already talked about it. When there's a lot of distension, you can put an NG tube, but that doesn't prevent the patient from taking oral sips of fluid. So this is a case. Sarah is a widower. She is supported by her children living in the UK. Okay, she is a widower. She is in the UK. Her children are in the UK. She is staying alone over here with some caregiver, and she's 62-year-old, and she has CA stomach, 4th stage. Okay, and metastasis to the peritoneum and the abdominal wall, everything. Now, what has happened is that she had undergone surgery, palliative distal gastrectomy, and she is now being given chemotherapy. Now, after 2 cycles of chemotherapy, when they did a CT scan, they saw that the disease is actually progressing. Now, the thing is, vomiting and abdominal colic started. It went on for 2 days. She came to you with complaints that vomiting and abdominal colic has been going on for 2 days, but was still able to pass small amounts of stool daily. Okay, so Sarah had vomiting 3 to 4 episodes per day, which was unrelated to meals. Vomitus was bilious with partially digested food. On examination, she was dehydrated. She was not dehydrated. Her abdomen was distended and bowel sounds were sluggish. Palpable nodules were seen all through her abdominal wall and was mildly tender. Now, you are having some clues over here as to the vomitus being bilious, 3 to 4 episodes per day, okay, and still passing some amount of stool. So, where is the obstruction? Yes. So what happened is that because she was having so much of vomiting, a NG tube was put in, and she was told that this would be a temporary measure for deflating the stomach. Okay, so then a CT scan was taken and a small bowel obstruction was seen. Okay, now this small bowel obstruction should have come to your mind when the patient is telling you that around 4 episodes of vomiting is there, still passing small amount of stools, and that the vomiting is bilious, it's yellow color. So it's more like it is and a partially digested food. So it's more like in the upper part of the intestine itself, there is some obstruction. So this should give you an idea, even without a CT scan, some idea, okay, this is probably where the obstruction is, okay. And as she is opening her bowels, the impression was that it is more of a partial bowel obstruction than complete, yeah. So over here, we did say that she is passing small amount of stools daily. So it is not complete obstruction, it is partial obstruction. So what was the treatment that was given to her? She was given suppository, okay, Bisacodyl. She was given regular interval intravenous metoclopramide, 10 milligram every 8 hours, and intravenous dexamethasone 8 milligram per day. And for pain, she was started on pentanol infusion. Okay. So you think this is fine? She was put on laxative suppository. She was given metoclopramide. Okay. She was having partial obstruction, no? So, and she was given metoclopramide for her vomiting. So then it is okay. It will help in some movement, peristaltic movement also. So then it is okay. Intravenous dexamethasone, maybe that 8 milligram is not sufficient. She needs a little higher dose, right? Now what happens is that no bowel action was seen. So metoclopramide was increased. The dose was increased to 60 milligram per day. Okay. And marked clinical improvement was seen in 2 days. And the NG tube had very little collection in it. No more vomiting. So the doctor told, okay, let's remove the NG tube. And Sarah was started on oral feeds. And intravenous metoclopramide and dexamethasone were continued for 2 days and stopped after that. 3 days later, she started vomiting again. Now, what went wrong here? What do you think went wrong here? Everything was going on fine. 3 days later again, back to square one. What happened here? What do you think went wrong? She was fine, right? Everything we started, all that metoclopramide and suppository, all that. And then everything was stopped. So what should have been done? Yes. Nobody is answering anything in the chat box. Yeah. What went wrong there? How come after 3 days itself everything came back? So what happened over here is that all of a sudden everything was put to a stop. So what we need to understand from this is that how medications have to be tapered down. Okay, slowly the doses have to be brought down and the patient should be on oral medications and observed. So 3 days later she started to vomit again. She had 3 episodes of vomiting, which was moderate to large amounts of bilious vomiting. When you read that itself, the first thing that should go in your mind, this is small intestinal obstruction. She was recommended on IV metoclopramide 60 milligram per day and dexamethasone 8 milligram per day again, and also ranitidine 150 milligram per day to reduce her gut secretions. And with all that, Sarah's symptoms kept persisting. So we know that metoclopramide, it was at a higher dose that was increased, that was helping her, okay, and that's why again she was put on that same dose, and dexamethasone also. Now we know that dexamethasone 16 to 24 milligram is what is needed. So when that was started itself at a low dose and stopped right after, in 3 days time itself she started recurring her symptoms. So this didn't actually help her. Finally, it was talked with the patient's family. Now they start talking to the patient's family. Patient's family is not here, they're in the UK. Then there was a telephonic conference that was done, and goals of care was talked to them, and she was also asked for whether she likes to keep the rice tube in. She said that she likes to keep the rice tube in for decompression, and so that she could even take her oral fluids occasionally. So they talked to the oncologist, and the oncology team also came to a conclusion, yes, probably we should stop all treatment, and it is comfort care which is best for her. And she was returned home with home hospice support. Okay, there was a home care team that kept meeting her, and this is just a case scenario that was pulled out of a journal just to point out where things went wrong and what could have been done better. Okay, so probably when it was an advanced stage of disease, the goals of care should have been discussed earlier, so that this prolonged admission could have been avoided. And dexamethasone we should have started at an earlier, we should have started at a higher dose, and metoclopramide and dexamethasone both could have been tapered, and it could have been continued as oral medications, and slowly bringing down the dose and then stopping it. Okay, that should be done in a span of like 10 days and all that. Okay, so what I also want to tell each one of you, one word about bowel irrigation. You must have seen so many patients with colostomy, isn't it? So many patients with colostomy, how sometimes life just comes to a standstill because they are not able to go out there and perform, their social life, because they have a bag there which is full of fecal material. They feel that they are not clean, and they refrain from going back to work. I personally know a doctor who was so reluctant, even after his complete chemotherapy and surgery. He was an orthopedic surgeon. He just was so depressed because he could not get back to work after his successful treatment because he had a colostomy. And that is when he was introduced about bowel irrigation. Bowel irrigation is nothing but irrigating the bowel with fluid, okay, with water, so that the bowel is washed off daily, made into a routine, okay, so that every day, it is only once that the bowel excretes, the colostomy excretes out. Otherwise, there is always some amount which is trickling into the colostomy bag, right? So through this method, there is a very regulated fashion in which the fecal material gets collected into the bag. So here, for bowel irrigation, these are the 4 important things that are needed. There is an irrigation tube with a cone tip. You can see the cone tip. So what is done is that in the irrigation bag, lukewarm water is put and it is hung, okay, and the cone tip is attached into the colostomy, into the ostomy. It is put in there, and the bag is let to run. The fluid goes directly into the intestine through the cone tip. And once the entire fluid has run through, then the irrigation sleeve is fit onto the ostomy, colostomy, so that all the water and the fecal material gone in is thrown out through the irrigation sleeve. Okay, so this I shall show. This is how it would look. Okay, now through the irrigation sleeve, you can see how the patient is placing the other end of the irrigation sleeve into the commode, so that all the excreta is gone. So this is practiced every day at the same time in the morning hours. Say suppose for example 7:30 in the morning. So you ask the patient every day 7:30 religiously do irrigation, and do this for 21 days continuous. 21 to 28 days continuous, please do at 7:30 in the morning. So after that, the patient will observe that even after he doesn't do the irrigation correct at that time, the excreta is passed. Okay. So this is what we did today. We looked at the different types of intestinal obstruction, the symptoms, how to diagnose, and how to treat it, right? And with that, we come to the end of today's class on bowel obstruction. Yes. So now I think we can move on to the case. There is a case presentation today, right? If anybody has any doubts, we can definitely discuss on it after the case presentation. Okay.
Thank you.
I think Ms. Pramila was presenting the case today, right?
Yes, ma'am.
Yeah. Would you like to share your presentation and start?
I'll share from my end, ma'am.
Okay.
Good afternoon, ma'am. My name is Promila and I work in Faridabad in labor room. Diagnosis is diarrhea. Mr. Patient की present complaint है loose and watery stool from 2 days, abdominal pain, and nausea and vomiting 1 day, loss of appetite is 2 days. History of illness: the patient has no past medical and diabetes mellitus, hypertension, etc. The patient has no past surgical history. Examination: ill appearance, sunken eyes, dry mucous membrane, lethargy, decreased level of alternate. Treatment and treatment modelized use of diarrhea are: maintain fluid electrolyte balance, provide oral rehydration therapy, antibiotic and antidiarrheal medication were provided. Psychosocial aspect: when the patient was hospitalized, the patient anxious about hospitalization due to financial problem. The patient was talked to, any unnecessary anxiety was allowed by talking to the patient. Uh, Major medications that are provided during treatment was rehydration therapy, zinc supplement, and antibiotics, cefixime, antidiarrheal, lepromide. The main concern the treatment diarrhea are the most severe threat posed by diarrhea dehydration. During the episode, the diarrhea water and electrolyte include sodium chloride, potassium, and bicarbonate are lost through liquid stool, vomit, sweat, urine, and breathing. A person with diarrhea become dehydrated when these losses are not replaced. Summary: during my posting, I come across the patient complaint of during the care study diarrhea. The chief complaint include loose and watery stool, abdominal pain, nausea, vomiting, loose and vomiting. On examining, the patient shows signs such as ill appearance, sunken eyes, dry mucous membrane, lethargy, and decreased level of alertness. The treatment modelized involves rehydration therapy, zinc supplement, antibiotics, antidiarrheal medication. During the treatment, good IPR should be maintained and instructions should be given about care and management. Discuss point: how to address the major concern of the patient. What will be the recommended primary level of treatment? Non-pharmacological measure in treatment of watery stool. Thank you.
Thank you, Pramila. So, this case, was it a patient that was there who had come to the labor room? I mean, to the gynec department, because you are
Yes.
working in the. Okay. So, this patient is pregnant or postpartum?
Um, postpartum, ma'am.
Okay. Okay. So, how to address the major concern of the patient? So this is her major concern was diarrhea here, right? So there was some treatment that was given for this patient, right? So apart from that, was there, like, this is her physical symptom. Now in palliative care, what we need to understand is that any symptom, okay, there will be always multiple dimensions for that symptom. So we in palliative care, we do not just look the symptom as a physical symptom, but we should also look and treat the patient as an individual, as a whole. Okay, so when you tell me what is the major concern of that patient, I'm thinking, okay, she is having diarrhea, she is feeling dehydrated, severely dehydrated, she's in pain, okay, loss of appetite, all that is happening. But what is the other concerns? Because of all this, she's not able to feed the baby. Is that a problem? Now, what is the other ways happening around it? The child is not getting enough breast milk, the child is going into also dehydration. Is there any other ways in which, now that she's put on antibiotic, is there any other ways they are trying to feed the child? Is the child being given proper or recommended supplements, or are they just giving like some water or some cow's milk, something like that? We do not know. So there are so many things in and around it. Are they able to afford the treatment which is being prescribed? We are writing for the patient, like I did see the a prescription saying cefixime antibiotic, zinc supplementation, all that, loperamide, things like that. So is that giving her any other concern? She's not having money to buy it. All these things. So, what do you think, Pramila? Is it just the physical concern that you saw that day in her?
Mm.
Do you think it was, something more concerning to her? Or is it just that she was tired and it was the physical symptom that was bothering her? No, it's just a general question. No? Since you had seen the patient, I was just asking. We were just curious to know, that's all. Okay, so let us see then the next thing. So what about the treatment? Can you just move to the treatment slide? Not that. There was another one which said the antibiotics, cefixime, all that, zinc supply. This one. Okay. Now this is open for everybody. Please use the chat box to say how you would like to modify this. The patient was asked to give rehydration therapy, zinc supplementation, antibiotic, antidiarrheal, loperamide. Okay. So, yes, Sunita was saying about ORS. Yes, rehydration can start at home itself, right? So that can start even at home. If they have ORS, well and good. If they do not have ORS, it's about taking a pinch of salt and a spoon of sugar, right? You can mix it into water, and that's how you could prepare. In a 1 liter bottle, so that can be used, right? So otherwise you can have the ORS preparation. Then Sunita was also telling about tab metrogyl. Okay, mostly like when there is some severe gut infections, you are thinking about anaerobic bacteria, so metronidazole is probably thought about. And Sunita was also talking about, then why can't she be advised some semi-solid food like khichdi? Again, that is another. And Seema says yes, nariyal pani is also there. It is like as pure. and that can also be given as ORS for rehydration, right? So that is something which can be done primarily at home. So even before they come to the hospital, right? Pramila also says about rice water, kanji with nice salt. If it is given, it really is helpful. Yes, Sunita talks about curd. Now, what is there in curd? Curd has probiotics, okay? Probiotics which help to replace the gut bacteria. Now, what happens when there is severe diarrhea? When there is severe diarrhea, there is the good bacteria in our intestine which gets flushed off in the process, of severe diarrhea. So when the good bacteria is gone from the intestine, there is no provision for digestion. So curd or sporolac, these are all ways in which you can supplement and give the good bacteria back into the intestine for digestion. Okay, so we can advise a patient for curd or sporolac or lactobacillus preparation, neutrolin B, things like that. Enterogermina may be a little more expensive, but definitely neutrolin B capsules, neutrolin B syrup for children, all these are available. Okay, now food banana, it is high fiber, so it helps to make the stool bulkier. Okay, so less watery fluid is gone and more bulkier, it may help. Okay, so we have got a lot of suggestions here. And lopramide. Now, what is your take on lopramide? Lopramide, you think definitely lopramide, there's so much of fluid that is being lost. So what is your suggestion about lopramide? Everybody agrees that yes, we must give a patient who is having severe diarrhea lopramide. Is Pagol also okay? That also adds to the thing, but it is also this one, laxative. Yeah. So that has to be used with caution. Now, Kirti was talking about should not prescribe. Yes, Sporlac should be given and not lopramide. Yeah, what I would also suggest, okay, if there is some amount of infection in the intestine, okay, the fecal contents, all that is all infected, okay. Now, when you are giving a lopramide, you are just stopping the action of the intestine. That is what lopramide does. It just stops the action of the intestine, okay. So, everything is just stationary. It is just there, stopped. Now, what you need is not that all the infected bacteria, everything just stops there, sits inside itself over there. Now, what you need is that to decrease the loss of fluid, the loss of water from the body. So, what you can do is that there is something which is called as Resicodotril. Okay, Resicodotril. It is available in Redotil brand name or Enough, things like that. Okay. So what happens is that it helps to increase the bulk of the stool, and therefore it helps to decrease the amount of stools. Okay. Now also at the same time, you can give probiotic like Neutrolin or Sporolac. Okay, and this will also help to replace the gut bacteria, replace it and give the good bacteria into the stomach back, into the intestine back, sorry. And again, straight away, I'm not sure if cefixime was needed over here because the patient was having was not having any fever, isn't it? So maybe we could have tried with ORS, we could have tried with Sporolac and zinc supplements. Zinc supplement, definitely it is very good even for small children, very good, helps to improve the immunity of the gut, okay, of the intestine, makes it more healthier. And with that, you should observe if, and also something you can give for nausea and vomiting. Maybe ondansetron, Emicet will help at this point. Okay, if it causes some amount of constipation, also that will be good for the patient, right? So with this, you can think that okay, this is good. these medications, if the patient is recovering, well and good. If the infection is not settling, patient still have diarrhea, then you can think about adding the antibiotic. So try to restrict the use of antibiotic if there is no clear indication. It is definitely a mild infection that has come in, but if you can treat it along with supportive medications at this point, you can try that. Okay. And if there is fever, definitely it is a call for starting antibiotic. Okay. So ofloxacin with tinidazole, ornidazole combinations, all these are available. Antibiotics, different antibiotics. Okay. Norflox, all these things can be helpful for diarrhea, infective diarrheal disease. Yes, so diarrhea was one complaint she had, abdominal pain was another complaint. So for abdominal pain, probably you can advise some this thing, cyclopam tablet, or some buscopan injection. If she is in the hospital, you can ask them to just give one buscopan shot. That will help to, because it has an anti-secretory effect, it will help to bring down the secretion, so there will be less diarrhea, there will be less vomiting, things like that. And loss of appetite for 2 days, it's probably because of the infection, so, and the repeated diarrhea and vomiting. So probably that should slowly recover, and you should check for the vitals. If the BP is on the lower side, you will have to think about giving IV fluid. Okay, and that is also another thing which has to be looked at. Again, continuous diarrhea. Okay, continuous diarrhea, something that we also neglect is that there may be excoriation in the anal area, which can be painful for the patient. Okay, so that has to be also looked into. You can advise zinc oxide paste around the anal area, or you can advise for sitz bath in the anal area. Okay, right, so that is with that. So what was the other concern? Non-pharmacological measures in the treatment of watery stools. I think pharmacological, something which is not involving medicines, something at home that we can do is preparing the rehydration solution, or even like tender coconut water and things like that. And preventing dehydration is the most important step, be it any diarrheal issue. What we have seen across all ages, especially small children. So what that is one thing. And also some home remedies, like some ginger and jati, that seed, the jati patri. I'm not sure what you call it in Hindi. In Malayalam we tell jadikya. So sometimes that is grinded and the paste is given, or sometimes even ginger juices are given. So all these are constipatory. They are anti-secretory and constipatory. They help to bring down the secretions and induce constipation. So that is why that can be tried also at home. So these are generally what I could think of. Would any of you want to add in anything more? Please welcome. Yes, Sunita says black elaichi. Okay. Anything more that any of you would like to add in? Or any other questions regarding this topic that we discussed today on intestinal obstruction?
The session is well clear to everyone.
I hope nobody is sleeping. So I also request that all of you should liberally use the chat box, okay, for all your other sessions also, because nobody is less. So all of you are practicing in your own areas and seeing a lot of patients, and you will be seeing patients with these complaints, and some things that you may be doing which we may not know of and is actually good for patient, you can share it here. So this is always a place where you can, all of you can share what you all are doing. It's a mutual learning. Okay, so in the coming sessions also, please try to do that. Okay, not stay quiet and away from the chat box. Okay, thank you very much.
Thank you, ma'am. Thank you for your wonderful
Yes,
session.
thank you, Pallium.
For taking over in such a short notice.
That's all right. Yeah.
Thank you.
Okay.
Thank you,
Thank you.
Meena, for presenting the case presentation. Thank you all for participating. Thank you. Let's see you in the next session. Bye.
Bye.